Should I get started, Osama?
Sure, go ahead. Or do you want me to get started? Okay.
Yeah.
All right, so we'll start with the transforaminal route. So my name is Osama Kashlin. I'm a surgeon at the University of Michigan. So me and Dr. Lynn McGrath here from Cornell will be demonstrating the transforaminal route. Thank you to the Seattle Science Foundation for giving us this podium to give this talk, or to show this for this demonstration. So the transforaminal route is a great approach to get discs in the lumbar spine, but also in the thoracic spine. L5-S1 is the part that's a little bit difficult because of the iliac crest, and usually for L5-S1, for most cases, you do the interlaminar approach, which you'll see in a little bit. In terms of the transforaminal approach, the first thing that we want to do is really to get a perfect AP and a perfect lateral. So if you'd be able to show us the X-ray here. So it's very important to get a perfect AP, a perfect lateral, because you're really using that to guide your instrument through the foramen. A lot of people use navigation, so you're able to use either conventional navigation with O-arm or any type of navigation, or there are commercially developed ones that are used only for endoscopy. But either way, using conventional radiographs or navigation, it's really the same, the same way of doing it. So we'll get an AP here first and a lateral, just to demonstrate what a perfect AP and what a perfect lateral is. We kind of made some incisions here just to make things go faster, and we're really aiming for the L3-4 disc space. So we'll show what an AP looks like here. So for this, donor, caudal is on my left and cranial is on my right. So if we could take an X-ray there. Okay, so looking at that X-ray there, so you see what you want to look at on the AP is that the pedicles are perfectly bisected by the spinous process, and what you want to see is that the inferior aspect of the disc space is flush. So that's a perfect AP. Maybe it's a little off there, but good enough. And there are two ways of accessing the foramen. There's a trans-SAP, a transforaminal. They're both kind of in the family of transforaminal approaches. So the first thing that you want to do is figure out your midline. So we already did that earlier, so if you could take a shot here, please. So that's another shot here, please. Okay, so that's a perfect midline shot. You want to make sure that you kind of mobilize the patient. You do want to wag the patient to make it a perfect AP. Don't change the X-ray at all. So now that we do that, what we do is we mark different lines on the body. You put an 8 centimeter, 10 centimeter, 12 centimeter. And the reason why you want to do that is in the lumbar spine, when you're starting, let's say at L5-S1, usually it's between 12 to 14 centimeters, and then every level above that, it's 2 centimeters less than that. So for L3-4, we would kind of say it would be between 10 to 12 centimeters. And that's what it ended up being in this, in this donor. So after you do that, what you want to look at is to see what your approach angle is going to be. So there are many ways of looking at the approach angle. What I do is I usually look and see where the lesion is. Is it a migrated disc inferiorly, superiorly? Do we need to go more medial, which means I want to start more lateral? But the traditional way of doing it, or kind of the way that works the whole time, is if you get an X-ray here, you want to cross the top of the pedicle on the same side of your approach X-ray, and then you want to get the bottom of the pedicle on the other side. This is a way to kind of, it's like a standard way. That's what I would say if you had to do this, you had to pick one way of doing this, is probably the best way of doing it, because you can always move your endoscope once you're in there. So then you put your incision based on either the landmarks that we talked about, but the best way of doing it is, can you do a lateral, please? So the best way of doing it, you want your approach angle on the lateral to be between the line where it joins the facet joints and the line that joins the spinous processes. So what you want to do is that you kind of put an instrument to touch the skin, and there are many ways of doing it, but this is the way that I think is the easiest. So X-ray there, please. So I don't see the instrument there. X-ray here, please. So you start seeing it now, starting to touch where the line connecting all the superior or the spinous processes are. But again, as you go more lateral, that line becomes more. So here it's between the facet joint line and the spinous process line. So this is a good place to start. And based on the checkpoints we said earlier, between 10 to 12 centimeters, and here it's actually perfectly on the 10 centimeter line. So now that we have our approach angle, we have how far we want to start, we start this process. So if you can if you can go back to AP, please. In the AP, again, it's important to get a perfect AP. So you have to wag it either cranial caudal to get a perfect AP, and we ended up having to wag it a couple of degrees. So what you want to do is you either use a Jamshidi needle or use a spinal needle. Either way works. I usually like to use the Jamshidi needle because you could either do the trans-SAP approach or you could do the transforaminal approach. And a patient like this has a humongous foramen. I always aim for the SAP, but I bet you I'm just going to slide right into the foramen. And if that works, then it's all good. So I just take a AP. I guess I may be a little bit high there. AP. 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 Okay, so let's see. This looks like it's still a little bit high. Let's see. AP, so what you want to do? AP. Okay, so that might be a good spot there. So I feel like I'm on bone here. So if you can do a lateral, please, that would be great. So where you want to end up is the final shot before you put your endoscope in. You want to be on the AP on the medial pedicle line if you're in the lower lumbar spine. In the upper lumbar spine, you want to be at the mid pedicle line because the dura pooches out more. And on the lateral, you want to be on the posterior where the PLL is. So here, we're probably a little bit too ventral. So can you come back to an AP, please?
Osama, are you doing these on a Wilson frame or a Jackson table? Or
so that's a great question. So Wilson frame is the best because it opens up the foramen more. In a patient like this, the foramen is humongous, right? So you could do it either way, but it's probably best to do it on a Wilson frame just to enlarge the foramen. AP, please. AP. Okay. AP. Okay. All right. Can we do a lateral here, please?
Osama, on that, did you change your trajectory if you have an inferiorly or a superiorly migrated disc? Anything like that?
You know, in my opinion, you go for where your lesion is. So if your lesion is inferiorly migrated, you want to start a little bit more cranial to go more caudal. If your lesion is central and at the level of the disc space, you can kind of get your angle to be more flush with the disc space. So it really just depends. So in this situation here, you see the foramen is huge. I tried to aim for the SAP, but it kind of slid into the foramen. So this is actually a great starting location. You're at the PLL on the lateral, and on the AP, you're on the medial pedicle line. We're at 3-4, so this is a level that, you know, do you aim for the mid pedicle or medial pedicle? That just depends on your preoperative MRI. But here, this should be a good place for us to start. And if you all have any comments or anything, please chime in.
And do you monitor the nerves, this part?
Absolutely. So, you know, we monitor nerves now. So part of this ESRG, we're trying to see if we need to monitor or not. But for now, most of us are monitoring. Mm-hmm. Yeah. Mm-hmm. Just to make sure that you're not, you know, you're not injuring the exiting nerve root. Mm-hmm. But again, especially if you're doing the trans-SAP approach, that might not be necessary. Mm-hmm. Okay, so now can you come back to an AP, please? Let's just check to make sure that we didn't slide out or anything. Okay, so we're still in the right place there. I'm just going to kind of X-ray. So I pushed in the spinal needle kind of deeper than what we usually do, but just to make sure that everything stays in place. Okay. All right, so now we'll do the reaming. So there are multiple ways of doing this. This is a huge foramen, so there are multiple different sizes of reamers here. You could start with a small reamer, go to the middle-sized reamer, and then go to the largest reamer. The safest thing to do when you're first starting is to go from smallest to largest. Here in a large foramen, I'll probably just go straight to the largest one, especially in terms of time, so that we can get to see the interlaminar approach. So what we'll do first is just put in all our kind of dilators in here. Thank you. So there are multiple different systems of how to do this. So like I said, I'm just going to go all the way. So it goes green, and then yellow, and then red. And between each color, there is a reamer that matches that. Okay.
And Osama, do you ever just skip the reaming and just go straight to the scope?
So that's a great question. A lot of people do that. There is a kind of 1 in 3 dilator that you could put in there. So this is this here. If you have a large foramen like this, honestly, you could probably just use this. Just do a 1 and 3, and then put the kind of your working channel in there, and then use the drill more than using the reaming. But reaming is way faster, especially in a foramen that's tight. So the example that Christoph had earlier at 5'1", I mean, it would take forever to drill bone there. So I think reaming makes it a lot easier, in my opinion. I don't know what you all's thoughts are about that.
Yeah, no, I feel the same way. If it's a collapsed and big facet joint, then I prefer reaming. That will make the just bone removal a lot faster. Absolutely. And sometimes I think you can drag the bulging of the disc into the disc space during the reaming, and then so by the time you get the scope in, the fragment is already kind of loosened up, and you could just pituitary to
That's a great point. That's a great point, especially also like if you're going for a synovial cyst, a lot of times you pop the cyst with the reamer, right. So there's a lot of things that kind of ruffles up things in there for sure. Right. So yeah, that's actually a great point for sure. All right, so if you could do AP shot there, please. Okay, so you could see here all our dilators made it to our perfect starting point, which is the medial pedicle line. My reamer didn't make it all the way. That tells me that there is some SAP, some deep SAP, some maybe pedicle that's in the way. So what you want to do in this situation, in this reamer, so you want to kind of err on reaming dorsally and inferiorly to get as much of that rim of bone as possible. So I'm going to err dorsally and inferiorly to kind of ream this area. So X-ray, please. X-ray.
Osama.
Yeah.
For that guide wire that you have there, for the new attendees who haven't done this before, is that ever concerning, or do you know that's in a good spot?
So if I wasn't sure, then you get a lateral. So could you get a lateral, please? So the lateral would show us that that is probably either in the disc space or in the epidural space. Obviously, if this looks like it's in the canal, then it would be worrisome for sure. But I felt the disc and I popped through the disc for sure. I try not to do that in real life. So actually here it's mostly in the epidural space. Not much of it is in the disc space, which is great. And that's a great final position. You know, you're at the PLL there. So on the AP, that's exactly where you want to be. On the lateral, that's exactly where you want to be. And then now really you put your working channel in there. So I'm going to take, can I have the pusher, please? So we put the pusher in here just to kind of not have everything pull out while thanks a lot, Lynn. Okay, so this is just to hold things in, because sometimes when you pull the reamer out, it pulls everything else out with it. So here, Dr. McGrath is going to hold the things in. Okay, perfect.
This gives me a nightmare from the endovascular
Absolutely,
suites,
yeah, it just changes, it just adds a lot of time when things get pulled out. Okay, awesome. All right, so now can you show us a lateral, please? Okay, so it looks great. So I'm going to put the working channel in. I don't know, do you want to do the approaches for both and then put the scope in for both? Or
yeah, maybe we can
just keep going all the way? Okay, cool.
Keep
all right. Okay, so then when you're putting the working channel in, there are two types of working channels here. So you have the one that is more kind of angled like that. That's for the lumbar spine. The one that's not is for the thoracic spine. And honestly, the transforaminal route is a phenomenal approach. But the game changer for it is for thoracic disc. And I know that we have a lecture on that and a demonstration, I think, tomorrow. So for lumbar spine, usually use the one that's more tapered. And as you're going in, there are multiple ways of doing it. So as we know, in this situation, you have your traversing route like this, and you have your exiting route like that. So you want to have the opening open to the traversing route, or the exiting route, so that you don't cross it as you're going in. And then you want to slide on the epidural space, and then you want to open up to look into where the SAP and the pedicle is. So again, I'm going to go in where it's open towards the exiting route. And then once I feel like I'm on bone, I twist it down. And then especially if you're going for a medial disc, I kind of push it in a little bit more. I slide on the PLL, and then you look up onto the pedicle SAP junction. So this is exactly where you want to be. Could you take an X-ray, please? So that looks like you're in a good place. So I'm going to pull all the stuff out here. Okay. And take the K-wire out. All right, now can you come back to an AP, please?
And just a point for all the participants in the lab, what do you guys typically do for your lateral entry? I know Osama, he marked 3 lines, but what about you, Dr. Yoon and Dr. McGrath? Do you guys, what techniques do you use to get your lateral entry? Because I think there's a lot of variability.
Yeah, I do the same exact thing, mark 3 lines, just to get like a general sense for where I should be, kind of a reality check. But then I use that same technique if I'm going to use fluoro, where I'll see where the level of the spinous process is on a lateral, and as long as I feel like I'm in line with the tip of the spinous process, that's another way for me to confirm that I'm at a good lateral entry point. Most of the time I'm navigating these at this point because I think it's just easier and quicker to navigate the dilator and to be able to kind of check over the course of the case without having to bring x-ray in and work around x-ray. I found that easier. But when I'm doing it with fluoro, I do it exactly the way Osama just did.
Helen, for our audience here right now that might not have as much experience with navigation, where do you think the biggest value is in what procedures that you see with navigation?
For sure, I think the cervical spine, I like navigating because one thing that I think gives surgeons pause about doing a cervical endoscopy is dilating over the cord, and having to put downward pressure to dilate over the cord. So what I like to do is total navigation. I take a spin right at the beginning of the case. I use the navigation to plan my entry point, and then I use my pointer as I'm dilating down to make sure that I'm not too deep. I am exactly where I think I am. I'm at the level of the fascia. I'm through the level of the fascia. And then I put the pointer right down on the lamina, and I just scrape along the inferior lip of the lamina to make sure that all of my bony landmarks I've identified kind of in my mind and on navigation before I start going down and dilating with the the actual working channel and everything like that. So for me, it just makes that approach safer, and I feel like I can move through it quickly and still feel like I'm doing it safely. And so that I think that's where it adds the most value, really.
And then when that, do you want to go ahead and?
Oh, yeah, of course, yeah. Okay.
Yeah,
So-
while Osama is talking, yeah, I think my landmark is I use a posterior spinous process and facet, and then kind of the same thing.
Okay, so as you're putting in the scope in here, you want to hold it, hold the working channel down with your index finger. There are many ways of doing this, but that's the way that I do it. So I hold the working channel down with my index finger, and I hold the endoscope like a gun. So you have the bipolar, please. So when you go in here, what you want to see is the junction between the pedicle and the SAP. There are two pedals here. There's a yellow one and the blue one. So yellow one is higher energy. The blue one is not. So already when you see here, when you come in here, can you hold this for a second, please? Thank you. I'm going to push this in here a little bit more. So already you're seeing the landmark that we're looking for. So I'm going to get this fluffy stuff, which is, the fat here out of the way.
What's the first thing that you look for when you put the scope in?
So for me, I look for the pedicle and the SAP junction. What about you all?
Exact same thing. And usually the reaming is a nice way to know, okay, yeah, I've been here before. This is where I was. I'm putting the scope in. I see that, and I know I'm on the right track.
And here, I'm going to get a better picture of it. But this is here. This is the pedicle. I feel it there. And then this over here is the SAP. And we're already, this is where the disc fragment would be. So this over here is pedicle, right here. SAP is down here, and this is going into the epidural space. And if you want to check that, you just take an x-ray. Can I have an x-ray here, please? And you'll see that we're hugging the pedicle here. Perfect. So see how low that we are? This is, again, with doing no work at all, we're already at the level of the bottom part of the pedicle. So let's expose the traversing route here. And in terms of navigation, another thing, honestly, these transforaminal approaches, especially working in an academic place, may I have a pituitary, please? It's really nice to have navigation for these transforaminal approaches. I've, kind of looking at the data since I started using it, and the number of passes that we've had to get to this spot here has decreased drastically. It's safer for patients, for sure. I think especially if you're in the learning phase, and I think it makes the learning phase better. I can have the bipolar again, please.
So Osama, why don't we let Dr. Yoon kind of show us interlaminar while you prepare the traversing nerve root?
Sorry, say that again?
Why don't we let Dr. Yoon kind of show us the interlaminar
absolutely.
While you prepare the traversing nerve root?
Okay.
You want to? Okay, perfect.
yeah,
Okay,
yeah.
perfect. Yep, that sounds
Yeah,
good.
do you want to come down? I'll start with the localization. I kind of prepared the cadaver. My name is John Yoon. I'm from Penn. Thank you, Seattle Science Foundation, for inviting me, and thank you, Christoph and Sakrit, for inviting me. So for interlaminar, actually, Osama did a beautiful job, and that's a lot harder. I think the transforaminal approach is, I think, in my opinion, very challenging approach to first learn. Interlaminar approach, I think it's sort of a working horse at the endoscope. You come down the midline, the anatomy is very similar. It's not as much fluoro shot to localize, so you can take a shot right here. I already localized the interlaminar space. I think it's actually
May I have
oh,
the pituitary,
that's good.
please?
So you can actually see, I don't know if people can see the x-ray, but this is the interlaminar window at 5.1. It's usually big enough to do discectomy through without doing any drilling. So my goal is to try to localize that, and I already localized it here. So take a shot right here. So this is just at the, so if you look at this, this is the spinous process. You can take a shot right here. So the spinous process is here. Interlaminar window is that big, sort of a pyramidal and sort of elliptical shape. And then here, take a shot here. This is where I make the incision. It's right at the junction. That's the facet. That's the facet line, and that's where the traversing route is passing through. So I make an incision. So I localize there, and I put down the dilators. And so usually it takes. You can come up a little bit. Usually take a couple shots to localize this on the AP. And I make an incision, and I put the dilator. So with the dilator, I can feel the sacrum, and this is the L5, the lamina. In the middle, soft stuff. This is the yellow ligament, and then I dog my tube there.
If you don't have a cutter like that,
and
I'll take the pituitary then.
Take a shot here. I just want to make sure that that is pointing towards. So I always put the tip of this instrument pointing in the same as my opening. This is a bevel tube. So I know, without looking at it, I know which way the bevel is opening up. So now let's go to the lateral. And I just want to make sure that my tube is not too deep. So you want to see this, the tube not all the way hanging out in the spinous process, but you want this tube just above the facet joint. So we know that it will be when I stick the scope. So that's perfect. So that's the facet line. If I angle up a little bit, there'll be a 5.1 this space. So you can actually, now I'm done with the fluoro. So you can move up. So at this point, I stick the scope in. Let me see the bipolar. I wish I had this 55-inch screen in my hospital. This is really nice. So usually there is like some soft tissue and stuff like that. I can clean this up. And Steve, could you help me with the focus? So Osama was doing this too. This is kind of like your finger. You can actually touch the tissue with your bipolar. And if I'm not on it, I can feel that this is the ligament. Okay? And so orientation, this is the bone, this is the L5 lamina. Okay? And if I swing down, this is the S1 lamina. So I can feel without actually sticking my fingers what the anatomy is. Okay. So after I do this, can I see the this is the punch.
A bipolar, please.
So John, I know for a lot of the people who are seeing the screen right now, I know that's very difficult for us to make out what you're seeing, but I think what you kind of highlighted is that it is a lot of feel in the beginning, right?
It is a lot of feel, I think as you get used to it, and the cadaver look is a little bit more difficult. Definitely the color looks different. So in the beginning, you're going to see a lot of red muscles, and as you clean up this fat and things like that, you're going to see the yellow ligament is very distinct color, and it's more. It appears very starkly different from the rest of the tissue. So, after you do that, and this is the punch. So, I always do this cases on a Wilson frame, where the patient's posterior element is stretched out. So you use a punch to remove the yellow ligament.
And John, I think it's really important that we're looking at your hands. I know that for transforaminal versus interlaminar, transforaminal is very easy in your hands, but interlaminar, it seems like a lot more is going on.
Yeah, so that's a great point. So transforaminal, you're sort of stuck in that one direction where you come in. Interlaminar, you actually want the degree of freedom. So what I usually do is I usually hold the endoscope between the thumb and the index finger, and I actually swing this irrigation on the opposite side. So my hand is kind of comfortable and free. And then using my finger, I can control the scope, so I can rotate. So if I want my bevel to be open, I can rotate it this way. If I want to look inferior or lateral, so this gives me enough degree of freedom. So here I'm gonna take down the yellow ligament here.
So John, going through here right now is people that have not done this before is how scared are you that you grab the dura, and what are your tricks to avoid it?
Yeah, so actually the dura, so I go layer by layer here. So, this is the yellow ligament here, okay? And as you go, as you know, the yellow ligament is actually got two layers. So there's the deep and then the superficial layer. So I go by layer, and actually, as I go through, as I make the small holes, I'm actually putting more pressure on the tube. So I'm actually doing some blunt dissection.
Bipolar, please.
And let me see the, okay, so that's the hole, okay? And you just saw, this is the epidural space, okay? So you don't have to make a huge window. Can I see the punch again? So what I typically do is I go slow. The ligament takedown is probably the most hardest thing to get used to. So you want to go slow layer by layer. And you don't have to make a huge opening in the yellow ligament. All you have to do is make a horizontal cut and actually use a tube to actually dilate that space. So after I make that window, can I see the carousins? Then the carotid is the same feel. So the blunt at the tip. It's on the reverse.
John, I noticed that you didn't do any drilling at all. I mean, this is because you're at 5'1",
Yes.
correct?
Yeah. So I didn't do it. Most of the times, you don't need to do any drilling in 5'1". Actually, can you rotate that real quick? So I'm just gonna speed up a little bit, okay?
But when you go a little bit higher and the window is a little bit smaller,
Yes.
I think that you do have to do drilling. Otherwise, to retract the thecal sac might
Yes.
cause a lot of problems.
Yeah. So at 4'5", very rarely you get away without drilling. So at 4'5" or above, you end up drilling a medial part of the facet joint. Not very much, but enough to get to the lateral edge of the tube. So I'm kind of just taking down the yellow ligament more laterally here. I can feel here that.
Osama, how are we looking with the traversing nerve root
So
and
we're
the
good.
transforaminal?
We're good now. I have the
you can
traversing
turn it
root
around.
already free here.
While John finishes up the interlaminar and shows us the nerve root, how about we go back to Osama?
Absolutely.
Yeah.
All right, so this patient actually had a little bit of a disc here, which is very interesting. So what do we have here? I can have the bipolar, please. So let me just kind of show you the anatomy.
Thank you
so
for
this
coming to
over here,
Seattle and treating our patients here.
So this over here is the pedicle right here. So it's the pedicle, that's where we were earlier. We're kind of, the SAP is up here. That's the SAP pedicle junction. So again, here's pedicle, inferior. This is deep or medial. That's the SAP there. And then, again, it's a huge foramen, but there's a little bit of a foraminal disc there that I removed. So you can see all the stuff that I removed here. And then there's our traversing root. So, beautifully decompressed. Still, I would take the stuff here. Usually what you want to do just depends on where your lesion is. If your lesion, can I have the bipolar, please?
So it brings up a great point for all of you guys. What's your endpoint? I mean, when do you know you're done with your decompression? It seems to be the most common question I'm asked.
Absolutely. So from my opinion, what you want to do is, again, it depends on where the lesion is. Does it look like a sequestered disc fragment? Does it not? What I like to do is make sure that the nerve is completely decompressed and that there's nothing touching it. Hofstadter talks about a little bit of a shadow. You want to do a little bit more than what you think because, in the endoscope, sometimes it looks decompressed a lot faster. So I like to see a little bit of a shadow, and I want to make sure that the nerve is decompressed from the top of the disc space. So the thing is if we have exposed a little bit more, so you'll be able to see where bone is, and you could do that with X-ray or with the feel. So here I feel that this is the end plate below. This is disc here. And if you look up here, I feel end plate right here. And we can confirm that obviously with the AP X-ray. So if I feel the top of the end plate, the bottom of the end plate, I see the pedicle here, and the nerve looks decompressed. There's a little bit of a shadow, meaning there's a little bit of a gap between it and everything deep to it or ventral to it, then that's when I say I'm done. I don't know, what do you all think?
Yeah, absolutely. That's the beauty of the endoscope is you can actually see usually the nerve root that you're interested in decompressing throughout the entirety of the course of where the compression was. So you can visually confirm because you're looking right at the surgical field when the nerve root is decompressed.
And I think, when it's decompressed, you see it pulsating too, but I wouldn't go by just the pulsations because sometimes there's still more disc there. When you first start, when you take a humongous disc fragment out, you think you're done, there's usually more. So I would say keep looking, or else, and again, I don't know if it gives you recurrence rates or maybe it just goes away on its own, but I usually spend more time, even after the big chunk comes out and you're super pumped and everyone's high-fiving, just to make sure that there isn't a disc fragment, an additional one, and usually, honestly, there usually is.
I have a question for you, Osama. John here. So let's say you had an MRI, a patient had a massive disc extrusion, and you went through everything, and then you sign them up for surgery, you bring them into the OR, and you get to the disc space with the same approach that you did, but you don't find a convincing disc herniation that you expected to see on MRI. What would you go through at that point? What would you do? So,
as we know, a lot of times disc herniations get better on their own. So the first thing that you want to do is make sure you're at the correct level, you're on the correct side, that you're not doing something not at the place that you thought it would be. Reevaluate your MRI, make sure what you're looking for, you're in the right place. And then after you confirm all of that, then what I would do is what I was saying earlier, just make sure the nerve is completely decompressed from above the disc space. So from the top end plate to the bottom end plate, you see the pedicle. If you see all that free, then the disc must have resorbed. A lot of times there are adhesions or there's a tiny disc herniation that's still causing patient symptoms. So I still have seen in those situations that those patients have honestly gotten better. But in that situation, you have to be super OCD that the nerve is completely decompressed. At least that's my opinion. Yeah.
What's your guys' algorithm? I mean, we got the transforaminal and the interlaminar approach to discectomy here. When do you use one or the other? What's your algorithm?
Can I have Carson, please?
Yeah, I mean, kind of go where the pathology is. So, if it's a paracentral, central, then I tend to favor the interlaminar, especially at 5'1". The crest is in the way. Getting into this foramen could be very tough. So that's my preferred approach. If it's a central, paracentral, even up to the lateral recess, I will do interlaminar. If it's a foraminal, extraforaminal, then the transforaminal makes much more sense.
Mm-hmm. Hey, Osama, two things. Beautiful technique. I really like, your handwork there. It's gorgeously coordinated.
Learn from the best.
No. Everybody watching right now is like, you can see how he holds the endoscope to the tool 90 degrees all the time. And so this is why he gets this beautiful visualization, right? So he does not block himself. Two little things is, would you mind just showing us to drill down the marginal osteophyte? That's what I've learned from Dr. Ralph Wagner. He's doing that always, and it's really helpful to get some extra space. And the second thing is, can you show us how you go up to the exiting nerve root?
Absolutely. Yeah. So let's start with with drilling the osteophyte. So like Dr. Hofstadter was saying. So if I go like this, I can't really see my instrument. I can't see anything, right? But if you have just a little bit of an angle between your endoscope and your working instrument, then you could see. And that's the benefit of endoscopies. You could see every bite that you're taking. There are no blind bites, or there shouldn't be any blind bites. So this is the marginal osteophyte right here. So can I have the drill, please? So the drill it's called a shrill. So it drills bone and it drills soft tissue. So this over here is the SAP here. That's the pedicle here. And as you go down and ventral to it, that's where the osteophyte is of the vertebral body. So you know that the drill is working if you see the pebbles in the screen. If you don't see the pebbles, then it's not really working. And then the drill also has an articulating tip. So this tip is straight, but there is an articulating one. So if you want to go more medial, this please. If you want to go more medial, then there is an articulating tip. So especially for more like central disc, can I have the drill again, please? So see, that's the osteophyte there, or that's usually where you have an osteophyte. This patient doesn't really have much of an osteophyte there, but this is, again, the back of the vertebral body of L4 in this situation, because we're doing L3-4. This is the disc space here, and again, I usually would take my time and make it look perfect. You want to close up any annular openings there with the bipolar to hopefully decrease the chances of recurrence. So that's the osteophyte here. So if you had an osteophyte that you wanted to get rid of, you do that here. If there's a lot of lateral recess, you could drill more of the SAP as well. So going back to the question about the interlaminar versus transforaminal, for me, anything from 1 to 5, I like to do transforaminal, unless there's also some ligamentous hypertrophy causing some lateral recess stenosis. In that situation, you could definitely do it transforaminal, but in my hands, I feel like interlaminar is better. And obviously, 5-1, I usually like to do interlaminar as well, even in patients, kind of the Kerrison, please, even in patients that maybe their anatomy is amenable to a transforaminal approach.
One thing I think is spooky when you're just starting out doing transforaminal is knowing where the exiting nerve root is. How do you, when you're starting out, get comfortable knowing where that's going to be, predicting where it's going to be, avoiding it, finding it? Walk me through that.
So yes, I mean, that's part of, so the exiting route is I think like an additional step that's really hard. So there are two ways of doing it. You could either follow the foraminal part of the ligament, which we took off here with the reaming, but if you follow that up, at the top of it, there's usually a little gap, and that's usually where the exiting route is. The second way, and the way that honestly I like to use more in this situation, is like follow the thecal sac all the way up, and then you know it's going to be in this area here. And you just have to take very small bites at a time. It's really, really hard sometimes in someone who has a very collapsed foramen. You have to do a lot of drilling to be able to get to that. So those are usually the two ways that at least I do. But any other?
So I think you brought up a great point. It's like, like the yellow ligament actually goes to the mid to tip of the transverse processes. So the yellow ligament also helps you to identify the exiting nerve root. So you just follow, like you're doing right now.
So so I'm just following the L4 nerve root here all the way up to where it takes off. And usually with the endoscope, because again, you're coming in from such a crazy angle, I'm sure the L3 root is going to be like somewhere up here. It's going to be it's going to look like it's in a different plane because you're coming in from so diagonally. But as long as you follow that nerve root all the way up, then usually it's fine. Can I have the pituitary, please?
I think it's an important note for the beginners that I think you shouldn't really be looking for the exiting nerve root when you're starting out. I think you can cause more problems by looking for it when you can just stay in the bottom of the foramen, and unless obviously it's an extraforaminal disc, then it's a different story.
Yeah, but knowing your safe zones, knowing, pedicle, SAP junction, you're going to be safe there. That's where you should start out. That's where you should, kind of find home and base the rest of your dissection off of is kind of critical.
John, how are you looking with the interlaminar?
Yeah, so great. So I don't know if you guys can all see. So I'm going to come out a little bit superficial so I can show the lay of the land. So that's the hole that we made in the annulus. Let me see that. So this is the lamina above. This has a little bit of ligament still attached here. Okay.
Thank you.
And then this is the yellow ligament. That's the S1 lamina. You can see that this is the thecal sac in the midline. So this is the spinal process up here. And this is the way past the midline here. Okay. And then this is the traversing root. This is the axilla of the root. And this is the shoulder.
Hey, John,
of the
just
root.
stay there for a second. So can you, if somebody, you didn't notice and your resident is coming in transforaminally, it didn't tell you, where would it show up? Show us.
Sorry?
Where would a transforaminal endoscope come in, like an approach? Where would you see it in your view right now here? So that
it will be coming through here. This is the foramen right here. So this is the traversing root. This is the disc space right here. And then the endoscope. So this is a facet joint. So your endoscope for the transforaminal will be coming through here.
Ben, can we do a side-by-side showing both endoscopic views?
Awesome. So so let me show the traversing route here. All right. So here's our traversing route on my side, okay? Right there. So it's a traversing route from both the interlaminar and the transforaminal approach. And then the exiting route here is I've started seeing it up here. So again, you have to look in a different plane. So I was just kind of clearing it out, but it's going to be right here over where this fat is. So I'm just going to start clearing it out so you all could see it. But it's in this fat plane right here.
So I think this brings up a great point. I mean, it's very easy to see what John's showing, right? But I think for a
Yeah,
lot of
the
new
parasympathesis. Oh, yeah, got
people who are trying to learn endoscopic spine surgery, it's very difficult to conceptualize what you're looking at, Osama.
Absolutely.
I think that brings a point up. I think transforaminal is harder conceptually, but easier technically, and vice versa. Interlaminar is harder technically, but easier conceptually. Do you guys agree?
Absolutely. Absolutely.
Yeah, absolutely.
Yeah,
And
absolutely.
then, you know,
Kind of the bipolar, please.
with the this is a lot like the view that you get from traditional open or tubular surgery. So anatomy will be a lot more familiar. So what I typically do is after I get this exposed, I want to see that shoulder. You don't want to take a disc out between the thecal sag, and then you don't want to go through here. Sometimes, disc herniation is very large. In those cases, I'll sometimes grab it out of here, but you can get a dural tear if you go between the thecal sag and the nerve root. So my preference is go from the shoulder, and I will use the a blunt nerve hook, medialize this traversing root, and then use this tube as my nerve root retractor. So I'll place this tube all the way to the level of the disc. Leave that nerve retractor, blunt nerve hook in place. And as you rotate, so that my bevel edge is now medial, opening to the bevel edge is to the lateral. And then now I have the nerve retracted. So this is all safe here, and this is the disc. So if I see a disc herniation, it will be right here.
Kind of the bipolar, please.
So
Albert does something very similar with this transforaminal technique. Albert, do you want to talk a little bit about how you take the cannula and transforaminal and do the same thing? So hold that button.
Yeah, so what Sakib is talking about is when we're doing transforaminal, the beveled cannula, when you go in facing down and have that sliding underneath the traversing nerve root, then it's really acting as a retractor. And so you can really advance it to the midline and address a disc herniation and then turn it up and then see the traversing nerve root. That's a good point, Sakib.
Mm-hmm. Osama, you want to show us what Albert just mentioned?
Say again, sorry? I couldn't hear you. What was it?
He just mentioned how he takes the cannula and goes across underneath the nerve root, kind of like retracting the nerve root, almost from a transforaminal angle.
Gotcha. Oh, so like when you retract the traversing root, you're saying?
Yeah, similar to what John's doing, but you're doing it from a transforaminal axis.
Yeah. I mean, I guess if we go back to our exiting or traversing root here, let's see where are we at. Sorry. Okay, so there's our friend. Can I have the bipolar again, please? So I didn't really bite too much of the SAP to be able to retract it too much, but I'll see if we can do that. Let me just get this retractor in. Sorry.
I don't know if you guys are seeing my screen, but
I think in the interest of time, you guys did an amazing job, so you deserve a big applause here. We'll go all applaud. Yep.
Thank you.
John and Osama, thank you so much for the demonstration. So we'll continue with our talk and then afterwards with the cadaver lab.
Awesome. Thank you all.
thank you.
Thank you. Great job.